While measurement in the upper arm is generally the first choice for obtaining a blood pressure measure, there are situations for which this may not be possible or indicated. Here are a few examples. If there is an increased circumference and decreased length in an individual's upper arm, such that the geometry is unable to accommodate the parameters of any cuff size, then a forearm measurement may be indicated. Or, measurement in the upper extremity may be relatively contraindicated in an individual who has undergone lymph node resection, such as after a double breast mastectomy. In this case, a calf or thigh measurement would be indicated. Or, perhaps the therapist is screening for peripheral vascular disease using an ankle brachial index. This calls for obtaining a ratio of the upper arm to calf systolic measurements and would require measurement at both locations. Finally, pain, fractures, and/or open wounds may necessitate modification in measurement location. In general, measurement at the alternate locations follows the standard measurement procedures and positions, with a few distinct exceptions. First, auscultation of the Korsakoff sounds would take place at the artery below the site of cuff inflation. So instead of auscultating at the brachial artery, as is done with an upper arm measurement, the radial artery would be used for a forearm measure, the popliteal artery for a thigh measure, and either the dorsal pedis or the posterior tibial would be used for measuring a calf pressure. It is notable that the bony structures of the ankle or wrist, or the anatomical position of the popliteal artery, may make sound transmission through the stethoscope more challenging. Therefore, palpation or use of a Doppler to obtain the systolic blood pressure might be indicated. Additionally, a supine position, as is seen in this individual, would be best to obtain a lower extremity measure, as it would limit muscular contraction. Finally, it is important to recognize that the diagnostic and category values established in the literature, for example, 140 millimeters mercury systolic and 90 millimeters of mercury diastolic, indicative of a hypertensive measure, are determined from an upper arm measure, and substantial variability may exist in varying parts of the arterial tree. Specifically, the systolic pressure may increase in more distal arteries, whereas the diastolic pressure would decrease. There can also be variability between the sides of the body at which the measure is taken. Therefore, regular measurement at each physical therapy encounter is recommended to establish each individual's blood pressure measurement and ranges.